it's important to consider, we would always think that there would be a negative to polypharmacy. And certainly when we're looking at medically futile therapy or duplicate therapy, or medication regimens that increase the risk of a side effect, I would agree that that would be a negative. But I think also there could be a positive side to polypharmacy when we evoke the principle of rational polypharmacy, when we pick medications that have a complementary or a synergistic mechanism of action, that can be very beneficial for the patient.
And I think we also need to consider the climate that we're all practicing in, which I think presents a multitude of challenges, but also a lot of opportunities. And when we're looking for opioid sparing strategies, ultimately employing medications from different classes will allow us to effectively treat the patient's pain while minimizing the amount of opioids or other controlled substances potentially that the patient is on.
When you look at the work of Ian Gilron, he's done a lot of work looking at, for example, morphine alone versus gabapentin alone versus both together in a lower dose, showing fewer side effects and a better therapeutic outcome.
I think it's something that they're probably very used to. I think in this day and age when patients have so many different providers, very rarely under the same roof. So they have their primary care physician, hopefully a pain specialist or a palliative care specialist managing their pain and symptoms. Then they have whoever is managing their other comorbidities, potentially an endocrinologist or a cardiologist, someone that's managing their surgeries if they've had hip or knee replacements, their orthopedic surgeon. And all of these people are often writing prescriptions and unfortunately not always communicating with one another, which kind of puts the burden on the patient, which is not always ideal. So I think in terms of streamlining the patient's medication regimen in the name of polypharmacy, I don't know that that's something that's always on the forefront. I think with limited time and other challenges that the primary care docs are facing, that's probably not always the number one priority, but it is an important consideration.
So I think it's important for the very reasons that Alex just outlined. The patients use one pharmacy. So at least the pharmacist can screen all the prescriptions written by this myriad of prescribers. I do, however, think that primary care practitioners are sensitive to the issue of polypharmacy. I'm very interested in deprescribing information, as is Alex, and the literature has shown that primary care physicians are very reluctant to stop a medication that is either guideline recommended or written by a specialist, or if the patient or their family seem very invested in a medication, the PCP is reluctant to deprescribe that medication. I think it's a laudable goal that all prescribers and practitioners be aware of the principle of rational polypharmacy so that we can find the sweet spot to treat a patient's pain. Certainly, we're living in an era where we're trying to reduce or minimize the use of opioids. So people forget about the golden oldies like the tricyclic antidepressants, amitriptyline, nortriptyline, dizipramine. These medications have a lower number needed to treat to get a good positive outcome than some of the more traditional medications such as opioids.
So gabapentin,
pregabalin, duloxetine. I do think it's important that people understand the pharmacology and how these medications work together, when to combine them, when not to combine them, and the effect it can have on the overall medication regimen. For example, pain management is not one size fits all. Not all types of pain will even respond to opioid therapy. Some types of pain are completely resistant to opioid therapy. Some are semi-resistant. So for example, if you're dealing with a patient who has cancer, metastasis to the bone, that kind of pain is only partially responsive to an opioid. There are much better targeted therapies for that type of pain. So I think that, this is a complex topic and it's certainly not one size fits all.
I think another example is acetaminophen. Oftentimes, earlier in the course of therapy, a patient will be started on acetaminophen and it's continued indefinitely. But a study from years prior had shown that patients on 70 milligrams of oral morphine equivalents or higher, the patients could no longer tell the difference that they were receiving acetaminophen. So I think it's always important to reassess whether all of the medications a patient is receiving are providing benefit. And if so, that's great, but also considering them from a toxicity standpoint as well.